Hello, exchangers of gas. Welcome to the Gas Exchange Podcast, where we talk about respiratory critical care. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. This podcast is part of our greater efforts at Inspire Respiratory Critical Care, where we provide expert panel discussions, pearls, virtual classroom lectures, and other philanthropic initiatives. You can find our podcast on YouTube, Spotify, and Apple Podcasts. On our website, www.inspire-rt.com, you can find links to our past recordings and many other resources. My name is Keith Lamb, and I'm the host. I'd like to welcome my co-host, Thomas Perino.
Well, hello there.
And today's very special guest, Dr. Tommaso Mauri. Dr. Mauri is a highly respected intensivist, researcher, and educator with many different areas of expertise. Dr. Mauri, we'd ask you to just introduce yourself and tell us a little bit about yourself.
Hi, thank you for the invitation. I'm very happy to be here chatting on my couch with you. I'm from Milan. It's sunny here, and I work at University of Milan and Milan Policlinico Hospital. I have been practicing ICU as an ICU physician since 15 years, more or less, and also interested in respiratory pathophysiology research for the same time. I share my time between clinical practice still. I have a night shift tonight in the ICU, which I love, and half time I do. So it's all mixed up with the research and teaching. Students come and we do protocols also during the shift in the ICU, and then I have a lab where we do animal research, preclinical research, and then teaching university. I love what I do. It's always exciting and challenging, and I love to have also international collaboration, friends around the world to discuss with, like you here.
Yeah, you're a big part of the plug meeting, which is the pleural pressure. Started off as the pleural pressure working group and has sort of expanded into not just pleural pressure and transpulmonary pressure, but EIT, high flow nasal cannula, like really just physiology, really broad. Do you want to just maybe briefly describe what the plug is for those who have not heard of it or know what it is?
Yes, sure. So the plug is very simple as a concept. It's a group of researchers and fellows interested in sharing their results. So we meet to share original data. It was born with my great friend Jordi Mansibo, who died a few years ago, a couple of years ago. And indeed, it's been, let's say, placed in Barcelona after he died, the main meeting. Once per year in Barcelona, once in Boston, but this year in Toronto. So let's say America and Europe. But people from all over the world come to the meeting. We meet. It's like a giant lab meeting for 2.5 days, and there are around last year there were 80 original abstract, you can call them, but they are not really abstract. So it's funny because if they are presented at the plug, all of the 80 will be published in the next year and a half. So it's very advanced results from large or small studies, but very new on physiology. So you said EIT, pleural pressure. So the idea is that what we're interested in is respiratory physiology in the ICU and let's say in the acute patient. So EIT is one of the methods to monitor. Monitor is for sure important, but also treatment, mechanism, clinical application, respiratory care. So the plug has a website, you can look at it, and we will meet end of September this year in Toronto.
Yeah, I hope to attend. It's close enough to home that I should make it. Yeah.
It's usually very fun, and we have also lunch together, dinner with some wine, and chatting, and it's a lot of social part too.
Yeah, it's very different from most conferences. Like a conference, typically there's many sessions going on at the same time. What I like about Plug is that everyone that is attending Plug is attending the same presentation, the same meeting. Again, at least how it is now. It may grow to a point where they need separate rooms, but right now, what's nice about it is that it's everyone is listening and participating in the same session all the time. So there's no breakout sessions. There's breaks, of course, with coffee, and there's usually a couple of vendors there where you can look at equipment, usually different monitoring techniques. And then, yeah, the meeting is quite nice, but it's definitely very strong physiology. I would say anyone who's listening, who's interested in respiratory physiology, it is really, I like the tagline. It's research with a taste. Isn't that what it says?
Yeah,
So yeah,
exactly. That's the subtitle. I think you said two important points. So one is the, let's say, competition with other congresses, which we don't think there is, because it's very different. It's a niche that
absolutely.
is not covered by other congresses. So if you want an update on clinical and research, let's say, findings and most recent guidelines, you go to a large congress. Now they are like courses, and you instead, if you're interested in understanding novel methods for research, novel results, and ideas to shape your research path, the plug is the place. While in congresses, this is usually small and inside the, let's say, the big program. The other thing is the relationship with the industries. We have a very clear relationship. Everything is on the website and disclosed. And the idea is that the relationship is not commercial. It's mostly to develop novel monitoring, treatment, ventilation modalities. And indeed, usually we have the last day, the last morning, we have an open discussion with the industries what we think should be the next ventilator, the next monitoring technique, what we miss in our clinical practice. So it's very open debate rather than just sponsoring, let's say.
Yeah, that seems to be a unique approach. I don't know of any other meeting that sort of operates that way. Typically, industry just financially supports the meeting and sponsorship, but
And
that's a
usually
great
it's a
idea.
closed door thing. Like if you're meeting with
Yeah.
industry because they want your opinion, it's a closed door. You know, you
Secret.
sign agreements, you sign the non-disclosure agreements. But
Yeah.
well, what I liked, I attended the last plug in Boston, and yeah, it was quite impressive that there was this open discussion, and like people
Exactly.
standing up these were like engineers from ventilator companies, you know, because and they're sitting and they're listening for the first, you know, for all of the sessions, and then this open discussion, they're kind of saying essentially, so what you're saying is that probably this is going to be a very popular monitoring technique. Should we implement it in our ventilators? And then they're asking why, and they're maybe sometimes even describing the complexities of doing that with their platform, just to give us an idea of you know, we might have these grand ideas of, oh, we should do this, and they're like, well, you know, it's actually quite complicated, and they might explain that, but it gives them an opportunity to have an open discussion with everybody, which I thought was very unique for that Congress. Yeah. Well, I don't even want to call it a Congress. It is more like you said, it's a
It's
meeting.
a
It's a meeting.
it's a lab me. I
It's a
like
big
to
lab
the
meeting. Yeah.
most
It's a meeting with
to have
food.
no, exactly. To be honest, the most similar, let's say, structure or concept are music festivals, if I have to admit. So
Yeah.
it's like a festival. Each one brings his own research, the best research he has, and we share and we discuss. Then there is no, let's say, leadership or someone teaching. It's just sharing the best of your
Collaboration.
results.
Yeah. That's great.
It's
Yeah, I
fun. It's
find
a lot of fun.
oftentimes that industry tends to come up with a technology or an approach with something and then looks for a reason to use it. And
Yeah,
After, yeah.
if I
instead of
have to say, for example,
what can we do with this thing?
a few, let's say, relevant addition to the physiological knowledge from the plug group, I think what is, for example, the POC, the occlusion pressure during occluded expiration, expiratory phase, let's say, expiratory hold, and POC developed by the group of Iwan Goliger is now also in the Lancet Respiratory Medicine, is a predictor of mortality, and it's very simple. It's very similar to the knowledge that we want to build. It's bedside, simple, feasible, cheap physiology because you just need your ventilator, you press an expiratory button, you have your measure, and we develop the physiological significance, what to do with it, what to target with your pressure support, etc. And this is like exactly the contribution we want to give to the clinical, let's say, community. It's translational. It's not only deep physiology. It's something that should be useful. And with DIT is similar. Now the paper on setting PEEP with DIT in control ventilation is out in the Blue Journal with a subgroup with improved mortality. That's another contribution from people from the plug. So it's really we are at the let's say interface between physiology and clinics, which we like.
Yeah, and the nice thing about including vendors in these meetings is, for example, there are some ventilators that don't allow you to do an expiratory pause during pressure support. So if the vendors are hearing multiple people presenting their data related to the measurement of POC, and if they hear well, it was challenging on this ventilator because we can't do an expiratory pause during pressure support. We have to use the NIF function. They have an opportunity to listen and see how many people are doing these measurements and realizing, okay, maybe we should allow an expiratory
A
pause
software
during pressure
change or
support,
something, yeah.
which sometimes is a software change because these holds do like they work in control in the assist control modes, just not in support modes. So, if they're hearing and they're seeing all this physiological data, it may influence them to make positive changes to their platforms.
Exactly. That's exactly the concept of our relationship with the industries. Or another issue that was discussed was the asynchronous. It's a very old concept now to mix them up and put all them in the same bag. Some are very dangerous, some are just markers, some are markers of too little sedation, too little support, some are markers too high sedation, too high support. So it's not the global asynchrony index or some of the asynchrony that is relevant, but the mechanism behind and what we should
The
do
power,
about
the
them.
duration, like the work with Luis Blanc, where
Exactly.
the asynchrony index used to be a good index. It's like, oh, these patients had an asynchrony index greater than 10%. So these were classified as bad thing to happen. But then when we further look at it, it might just be telling you your patient's ready to be off the ventilator the more asynchronous
Sometimes.
they become. So the question is, if the duration is long and the power, the intensity of the, for example, ineffective efforts or double cycling, it may be telling you need to change the mode on the ventilator. You need to move the patient forward. But when this is not the case, then of course it becomes a red flag that this patient is likely not doing well. But yeah, we can't just use the simplicity of the asynchrony index anymore. I would say it's way more complex than that. It's a good starting point. My patient has asynchrony, but then how you treat it and what you do from there really is well beyond just an asynchrony index.
Yeah, it depends from the mechanism behind the specific asynchrony of your patient in general. Because monitoring is about personalization, personalized medicine in the ICU. In our practice, in our approach, it starts from monitoring. Should be bedside, so should be cheap, should be available everywhere, but should be a lot of money.
Safety and personalization seem to be the modern central. Sure, do less maybe. Don't just do something. I had an old critical care physician when I first trained about almost 30 years ago. That I was a young RT. I wanted to do everything. I wanted to put everybody on the oscillator. I just wanted to do everything. I wanted to do it now. And he used to pull me to the side and tell me, "Don't just do something, Mr. Lamb. Stand there." Stand there. The opposite of don't just stand there, do something. And I think the longer I've practiced in respiratory care, the more I use that sort of as a central approach. That you don't
Yeah,
have
because
to do something.
if you start doing, let's say, even following guidelines, but doing before understanding, even in the acute care setting, it's not what the patient need usually,
Right.
because the time to understand delivers a much more highly effective treatment. And so you lose time, but you increase the effectiveness of your treatment, which is what the patient need. Not only fast, but specifically what he needs or she needs is what you need. For example, also the definition of ARDS and just the clinical syndrome to classify patient is no more enough. Now there is these names, subphenotypes, endotypes, whatever, but the point is ARDS in your patient. So ARDS is a clinical definition. What type of ARDS does your patient have? Low compliance, high compliance, hyperinflame, hypoinflame, recruitable, not recruitable. We spend 1 or 2 days, sometimes even 3 days in our clinical practice discussing this. What type, while we do say cautiously what is written in the guidelines, okay, but we discuss, and it's very different once you arrive to, let's say, group agreement in the group of the ICU physician taking care, or what kind of patient is that. Then the direction for treatment takes different paths. Early spontaneous breathing, prone position, ECMO, early extubation, tracheostomy. This comes after, not a scheme of treatment, but a discussion of what type of patient you have in front. front.
Yeah, and we've had this conversation with other guests about guidelines, just trying to explain to people that the guidelines are like the framework. It's the base foundation for what you then customize and particularly individualize the care to the patient. So you have the guidelines essentially look at all of the data and try to come up with some decision, but most of the recommendations are conditional, meaning one or two more papers could change the recommendation depending on the results, again, just based on when you randomly assign therapies to a patient. So the guidelines should just be a starting point, but then you don't end there. You should never end there. You should then understand the patient's unique situation and then build upon the guidelines and use other methods, techniques that have been shown to be effective. Again, maybe not at reducing mortality. We don't have data for many of the things that we'd like to do for individualizing currently, but definitely it's just a framework, right? It's not you shouldn't just follow guidelines and say, this is all we need to do. That's it. Like really, it's just a starting point for most people.
Yeah, exactly. Guidelines are a frame. You should be inside the frame, unless you're doing research with informed consent and ethical approval. But if you're in clinical practice, you have to stay within the frame work of the guidelines. But then within that, there is a lot of, let's say, nuance and differences and physiological adaptation that can really make the difference in terms of outcome of our patient. Another thing, I don't know if you agree, also the outcome, I don't think is anymore just mortality, because we want our patient to sit up, to move,
quality of life. Yeah.
Exactly, go back to work, rehabilitate faster. So really everything that is related to muscle use, neurological safety, let's say, of the brain, is very, very much relevant. And not only having a patient sedated, paralyzed, and perfectly ventilated. That is very old. And for this, as patient, I was discussing yesterday, now in our unit, which is a small unit because in Italy we have few beds of ICUs. Even with small units in Italy now, if you take an average, I think less than half of patients are intubated in our unit on average, even with the small units. This become even more true in large units, places where they have, I don't know, Australia, China, where they have 50, 60 beds. I was in Montreal 2 weeks ago, Montreal at the CHUM, very nice hospital, very new. There is this 60 beds ICU, but a lot of patients, more than half, I would say, always are non-intubated. And this is very different setting and we know very little how to monitor them, what is the physiological goals when the patient is worsening. And it's a very interesting and novel point, let's say, field, because hypoxemic patient before intubation were usually in the ED or the general ward or the pulmonology ward, but now they are coming into the ICU because we want to avoid intubation, for example.
Do you attribute, Tommaso, do you attribute fewer intubated patients to earlier extubation because of lower use of sedation and other medicine, or just a different threshold for intubation because you might use non-invasive approaches like non-invasive ventilation or high flow?
Well, for example, I can make an example. Yesterday, I was in the unit in the afternoon, and we decided to admit a patient who was worsening since a few days, increasing the FiO2 requirements, passing from no oxygen to high flow, poorly tolerant to the NIV. And so we decided to transfer her in the afternoon yesterday, made a transport inside the hospital with high flow system. And she was on, for example, during the transportation was on 80% FiO2, 50 liters per minute. So very hypoxemic patient, PF around 100. But she didn't seem to have the criteria yet for intubation, but we didn't want to leave her on the ward like this. So this is the way we are going. So we want to try to avoid safely intubations, not just forget the patient there and hope they don't arrive to intubation. So I think it's mostly both. Is both. Before intubation, having more closer having closer monitoring, so we keep them in the ICU and not leave them in the wards until they are decompensated, and also early extubation too. Yeah, for sure. With the reduced sedation, and we assess every day if the patient is ready to be extubated, and as soon as it's ready, we just extubate. We don't wait. We extubate patients also on a higher PEEP than 5 or 8, because then we have instruments for PEEP. We have CPAP, we have non-NIV. So it's both ends. We try to monitor patient to avoid intubation, and we extubate as early as possible. But the bottom line is that we have a lot of non-intubated patients speaking and chatting and watching TV on iFlow, NIV, CPAP, this kind of support.
Yeah, but
Yes.
you really highlight nicely the importance of monitoring these patients, right? Because sometimes when they are in a general ward area, the lack of close monitoring may make the reaction to escalate care delayed. If sometimes you can escalate care to a point where the patient then stabilizes, right? But if you wait too long, then for that escalation of care, by the time you get that patient and start to escalate the care, it may be too late. Like they've now spiraled and it's just impossible to get them comfortable and really give them what they need. They might need more flow, more FiO2. So monitoring really, I think, is key, and having, I would say, low thresholds to get a patient to a monitored unit. Once they're on a certain amount of FiO2 or a certain type of therapy, they really should, like, the utility of monitoring more routinely is really, I think, underestimated sometimes, how important that is, so that you avoid waiting too long to escalate care on a patient because of lack of monitoring.
So yeah, monitoring is, we've talked about this with other guests, anticipating failure of treatment and delaying definitive support, and how deleterious that can be. I'm assuming that you use the ROX index, Tommaso?
Well, that's very simple. Index can be used outside of the ICU. For sure, we use it SpO2, FiO2, respiratory rate. We always look at them and combine in the ROX index. I think that's a warning for the admission to the ICU. Then once they are in the ICU, we monitor more than that. Let's say we have monitors for, we have EIT, we have esophageal pressure, we have ultrasounds. There is a lot of exciting developments in non-invasive monitoring of non-intubated patients. I just saw yesterday a potential wearable, like a smartwatch, like a bracelet, simply put on the wrist of the patient and can monitor respiratory rate and saturation. Very exciting development in this. So our approach is a more than one simple monitoring, more than relying just on one number, but having always bedside and non-invasive monitoring, an array of numbers, let's say, and follow them up along the day, the hours. However, I think we go back to what Key was saying before, that we have to change our mentality, because these patients don't need that you do much. They need to talk and have relatives there and watch a movie, alternate non-invasive support from iFlow to NIV to CPAP, and a lot of monitoring. So we have to stand back. A lot of care should be done by respiratory therapists and nurses, not much from the doctor. The doctor is in charge mostly of the, let's say, etiologic, so the correct antibiotics, and the monitoring. And so this is a change of mentality, especially where ICUs are run by anesthesiologists, like in Italy, because anesthesiologists like to do procedures and move hands. Instead, we should be more, how do you say, contemplative, that you like to watch and contemplate the patient.
More think and less do, maybe.
Yeah.
Exactly.
Yeah, you brought up a nice point with the ROX index. When it came out, there was a lot of discussion, people saying, well, no one's going to intubate with one value. And it's like kind of missing the point that essentially it's a tool that could be utilized, as you mentioned, to stratify patients, right? Like you stratify them in terms of like where they should probably be in the hospital, right? If you have a ROX index that is not concerning, then it's probably safe to continue on the wards, and just using it as simply a threshold to monitor that patient more closely in a different unit is a very good use of a tool like that, because it's simple techniques, it's simple data points, but it doesn't mean that, oh, if they're a certain level, you have to intubate. It's like, well, there might be other things you can do first, but maybe those things need to be done in a more closely monitored unit. Yeah. So that's a good point.
Oriol Roca and Jean-Damien Ricard, who developed the index, are my very good friend, and I think they are very wise. If you read the paper, the way they presented it, there are three areas, the black, let's say, and that is very difficult below 3.85. If you make the calculation, the patient should be very severe to be there. Instead, above 488 or 5, whatever, it's a milder patient. I like always to say that most of the severe patients are in the between, in the gray zone, and that is where you need close monitoring rather than decision of yes or no intubation. And I think most of the patients that will end up intubated and needs ICU are in that gray area, which is the usefulness of the ROX index. However, it's always great to have some simple monitoring correlated with outcome based on physiology at the bedside. And the ideal that we are seeking is a monitor of respiratory drive. By now we have indirect sign, but we will arrive to that. So with some brain monitoring, that will be very interesting and relevant.
Yeah, that's all really important. You shouldn't use any kind of indexing system, obviously, or scoring system, a single system to make major clinical decisions like intubation. A lot of your work, Dr. Mauri, has been in like microphysiology and acute inflammatory processes in ARDS. And we like to take the complex issues and bring it to the bedside clinician. Like, what does this mean to them? So you talked very briefly about phenotyping at the very beginning of the podcast. Let's take that significantly hypoxemic patient that is on high flow and is not intubated yet. And talk to us about what you know about the microphysiology and ARDS and dependent on the etiology of the ARDS and how the bedside clinician should take that information that you have sorted out and apply it to the patient at the bedside. Like, what difference does it make to the clinician?
Well, I think this is a very relevant point. So my main, let's say, the biggest, overarching, let's say, topic for our research is why does a patient develop ARDS from pneumonia? This is a very relevant and interesting point, which we know very little about. A patient with ARDS intubated has a mortality of 30-40%. There is a moment in time, maybe at home, maybe in the ED, at which point he was or she was a patient with pneumonia, where mortality could have remained around 5-10%, no need for intubation, no need to ICU. So why does a patient develops ARDS for the same pneumonia? Let's say pneumococcal pneumonia, bacterial pneumonia, no? We don't know much about this. And now we are, especially in the lab, we are developing models to see whether, let's say, what is surrounding the pathological portion of the lungs, let's say the lobar pneumonia, maybe it could have a role. For example, we did experiments on ligation of the pulmonary artery. So when you have inflammation and you have pneumonia, you have some thrombosis, intravascular thrombosis. This increases the dead space. The dead space is ventilated, non-perfused or very little perfused. This develops regional hypocapnia, CO2, which is injurious by itself. So you have the pneumonia there, you have the surrounding regions with some thrombosis, and there is hypocapnia and additional damage. So this could be something that is not so, let's say, measured or assayed or in the clinical practice, which is the dead space surrounding the pneumonia. And this is one mechanism. Then we showed that collapse itself. So if you have a lobar pneumonia, there is a surrounding collapse because the weight of the lung is increased by the regional inflammation. And what is collapse is not necessarily inflamed. It could be just the surrounding part of the lobe without the infection, which is compressed by the weight. And we showed that collapse per se induces regional hypoperfusion because of hypoxic pulmonary vasoconstriction and additional damage, inflammatory damage there. These are two many. And the third that now is very, let's say, fashionable and everybody is investigating into it is patient effort, which is a patient self-inflicted lung injury. And the latest publication from our group showed that we studied 20 animals, apparently all the same lobar pneumonia with LPS, but very different injury to the lung that is contralateral, the one that started healthy without the pneumonia. So you let them breathe spontaneously for 24 hours, and some animals develop, let's say, bilateral lung injury, ARDS, and some don't. So we took a look at what are the factors correlated with these, and effort and respiratory drive is perfectly linearly correlated with this. So these you were asking about clinical applications. So these are all very relevant features that could be present in our patients that we don't usually measure much. So the idea is that you have a pneumonia, a regional pulmonary insult or trauma, lung contusion, something that starts regional, but if the surrounding lung regions are subject to this collapse, microthrombosis, and high effort by the patient because of inflammation, because of high respiratory drive, then the risk of spreading of the injury, which is a different type of injury, is not the bilateral pneumonia, is the lobar pneumonia plus self-inflicted lung injury is one part of the picture. There are others. We call them non-perfused and non-ventilated lung injury. And this is the path, in our opinion, from lobar pneumonia to ARDS. And interrupting these mechanisms is essential to prevent intubation. Is the, let's say, correct physiological approach to prevent intubation. The rest is more like symptomatic treatments to avoid intubation. Instead, this will be mechanistic. And you spoke about inflammation. We measured some interesting, let's say, biomarkers and effectors of this spreading of injury that could be relevant in terms of drug development. So rather than looking at systemic drugs like steroids, and we try to look for specific mechanisms that are amplified by this physiological mechanism that could collaborate in decreasing the spread. So the idea could be you have a patient with the pneumonia, you use some physiological non-invasive respiratory support, but on top of that, you may use specific drugs to prevent this mechanism. After having measured at the bedside, what is the highest risk of your patient? Is it a patient with the pneumonia plus high dead space, pneumonia plus high collapse, pneumonia plus high inspiratory effort, or a mix of the three, or 1/3 of these, 2/3 of the other? That will be, I don't know, the future that I see in this field. And you try to specifically prevent ARDS in that patient based on the physiology and the inflammatory, let's say, pattern of that specific patient. So this is the, let's say, clinical relevance of what we observe in the lab and in pilot, let's say, physiological studies in patients.
So it's always, so the inflammatory processes, it seems like if we look at overall mortality of ARDS, for instance, that primary ARDS without multi-system organ involvement has a lower mortality than if there's a secondary inflammatory process that then involves other organ systems and then increases mortality. I've always find it very interesting that there are some folks that can be exposed to bee venom and it just agitates them, and other people that get exposed to it that they kills them. And I'm assuming, not being an expert in the microphysiology of inflammatory processes, that there's similar corollaries with people who have a focal infectious pneumonia, and some of them that are exposed to that have higher effort will go on to have secondary inflammatory processes, and some of them won't. Is that a reasonable kind of assessment?
I think that nearly all the patients with ARDS die by multi-organ failure. And even though in some patients it can be still confined to the lung, if the lung does not improve and, for example, compliance remain low, the first, let's say, complication, the first, let's say, bleeding or a super infection will further decrease compliance, and remaining protective becomes very difficult, and ECMO is too late as an option, and that leads in the end to multi-organ failure. So sometimes let's say the multi-organ failure is evident already during the first days, and as you say, this is the most severe patient because it's very difficult to block this vicious circle. But in the end, that's where all the patient end up if you can't improve in some way their pulmonary lung, their lung injury. The inflammation within the lungs is what we need to target first, ideally, to prevent that vicious circle reaching the other organs. That's what I think. Another very interesting development in this sense is aerosol drug delivery with the inhalation, because that will be topical. But we need a better system to develop aerosol and more research on aerosolized drugs, because by now there is only some bronchodilators and some antibiotics. We don't have much in the ICU for this kind of patient, but that's a very exciting field. Also, the modulation of inflammation could be through aerosolized drug rather than by EV drugs, which we don't know what they do to the brain, to the kidney, to the liver, to all the other organs, which apparently could be relatively healthy in the beginning.
Yeah, I want to highlight something that you basically said without specifically saying it. But when you said that how important it was to sort of stop the cascade of the patient who just has pneumonia but hasn't reached this multi-inflammatory situation yet, to stop it, you didn't follow up by saying, so we need to intubate, sedate, and paralyze, which I think
No.
I think is maybe the mentality that some people have when they hear that something is bad. They're like, oh, when you say prevent it, they automatically go to let's stop everything. And while in some cases that may be the solution for a specific patient, I like that you highlighted trying to find other ways to reduce drive. So, if the patient is not on high flow nasal cannula, we know through many of the work that you've done that we can reduce work of breathing with high flow nasal cannula. NIV, whether NIV is injurious or not, or problematic in hypoxic failure, is still somewhat of a debate, but perhaps trying some CPAP with this patient to try and reduce the drive. Again, we have tools to try to reduce drive, and we don't have to automatically jump to intubation, which was part of the problem when the COVID pandemic hit. As you know, globally, many people were hesitant to use things like high flow or non-invasive in these patients due to a perceived risk of spreading the infection. Yeah. Sort of ignoring the fact that if you are wearing proper PPE, that risk goes down significantly. So we should probably not just go directly to intubating patients. We should try to reduce their drive. And I think eventually we got there, and perhaps maybe a little bit, I say sometimes the pendulum, I think, swung maybe too far, where maybe some patients we waited too long prior to intubation. We're talking patients that were not doing well for over a week, and then finally we're like, maybe we should intubate them now. But in general, I think you highlighted a good point without specifically saying it, that stopping this cascade does not automatically imply that you sedate, paralyze, intubate the patient. Like this is not the first step to stopping this cascade. There's other methods to attempt first.
Exactly. The way I see it, so delaying intubation is not a good way to avoid it. So you have to tell yourself, this patient is not going anywhere and needs intubation. But on the other hand, so I don't think avoiding intubation is a clinical goal per se. Avoiding intubation is the goal of the strategies that you decide, that you put in place in the beginning, but then you have to give yourself a limit to say, okay, yes, our strategy is failing and we have to intubate. But in a broader perspective, on research and the way we are looking, we know that sedation, paralysis,
we know that's bad. Yeah.
infection. So my ideal is that we will avoid completely intubation in the ICU near future. I don't know when, but so it's not physiological at all, intubation. So with time, safely, not again. Delaying intubation is not a good way to avoid intubation. So avoid intubation means to stop specific mechanistic pathways, whether it is inflammatory or physiological, by drugs, by intervention. So prone position is a very effective intervention that is and its benefits is a mix of decreased drive, decreased inflammation, better lung inflation. It's seems magical. We're still learning how it works, especially in non-intubated patients, but sometimes it's not feasible. So and sometimes the patient don't tolerate it, so we need also alternatives. PEEP in some patient works, but not in all patient. High flow in many patient works, but not in all patient. So we don't have to be fixated with just one intervention, and we don't have to avoid intubation by delaying it. But the path for research is eliminating, finding more physiological way to support the patient during acute respiratory failure without intubation and sedation and infection and all the rest that comes with it.
Yeah, geez, all this stuff is extremely relevant to respiratory to sort of recognize things that can be intervened on. Like, we know that the primary way to take care of these patients is to attack whatever's causing them to be sick. So if it's an infection, then attacking the infection. If it's volume overload that's causing take an approach with that. But all this stuff is really exciting, and we appreciate you being here today. We're gonna have you back because we still have a lot more to talk about. But we're gonna go ahead and wrap this session up. Dr. Mauri, we cannot tell you how much we appreciate you being here and sharing your incredible insight and expertise. And thanks, of course, to the listeners for joining us when this recording comes out.
Thank you. And
Thank
see
you,
you. You
Tommaso.
can come at the Plug meeting in Toronto and have a session from there of your podcast.
Yeah, that would be great.
There we go.
Yeah, if Thomas and I can get in the same place at the same time. Sometimes we do get
I know I can be there, but you're gonna have to get your butt up here, Keith.
It's a little further from me, but yeah, that would be really nice.
Okay, wait for you, Des.
Thanks for the invite. Appreciate it.
Thank you.
All right. Bye-bye now.
Thank you, Tommaso.
Bye, thanks.